Quick disclaimer before you listen. The World's Okayest Medic Podcast is an educational and commentary platform produced and recorded by me. What we say on here is not endorsed by any of our employers, and we are not speaking on behalf of our employers. Our commentary is our own. Finally, remember to follow your local protocols.
Boston EMS patch up there.
I do.
They're one of the few who are barriers to all of this, but we'll get by them.
All right. Sounds good.
All right.
All right. Steve Wood's back. You all know and love him. And you started the TAC Medic Whiskey podcast. You want to talk about that?
Yeah. So I was previously on a tactical team as a tactical paramedic with our good friend Ben Podsadlo, who you all know as well. And it was an interesting team because they were basically a regional team. I think 64 different towns contributed to that team. You know, some large cities, some very small towns. The officers, went through a selection process as most SWAT teams do. And, they would respond regionally to events, and they're pretty busy. I'd say at least, once a day you'd get something, be it a, barricade, which is most common. They did some search and rescue. They responded to large events. They responded to protests, things of that nature, high risk warrants. And the medical piece was the interesting part, because what they did was they contracted with a local ambulance company to provide a couple of selected paramedics. And I was not employed by them, but I became employed by them solely for that role. There were 5 of us, I believe, that were on the team. And, we had our phones and we would just respond, to calls that we could respond to. But, there were some issues with that, in that, we didn't do a whole lot of training. We really didn't train with that team very often. And we were kind of a separate piece. We weren't in the stack. We would stay in the Bearcat for pretty much anything that, required our response. And so we weren't really well integrated, in my opinion, into that team. And so for that reason, I worked on that team for 3 years and then decided to move on. The team that I'm with now is much different. So I've recently been integrated into a team. It's in a city just outside of Boston, and the model is really great. It's a great model. I'm primarily I'm their primary TAC medic. I go to all their trainings that I can attend. I'm integrated in. I do a little bit of teaching each time we train. I go to the range. I go to all their trainings that as I mentioned, I could attend, and my opinion is respected. I set up medical response plans that are integrated into their overall plan. Their training as a team. People feel I'm I'm integrated into their stack. So it's a team model that I think is safer. It's more in line with what I've wanted to do as a tactical paramedic. And so, I think probably inspired by you, I decided, and I also just, they assigned me just a cool name. So they're like, the TAC medics that they had before were like TAC medic 1, 2, 3, 4, and then they're like, we're going to make you TAC medic whiskey. And I'm like, well, that's just too cool to let that slide.
Cool.
With it. Yeah. So like,
I never had a cool nickname.
Yeah, no, nor had I. So I was like, well, TAC medic whiskey, I got to do something with this. So I decided to do a podcast. Honestly, like the first podcast, I wanted to just revisit the whole blood piece, because we're having issues with just ridiculous, arguments around alloimmunization and temperature control and all of these things. And so I just wanted really to just
these same men. Now, I don't ever get political, but it's men. It's these men that on their social media profiles and on their Twitter and stuff will have all of this stuff about healthcare equity and social justice. but then will mansplain that we should not be giving blood products to women of childbearing age because they may want to get pregnant someday and may have this less than fraction of a 1% chance of alloimmunization. I
Yeah.
said that these two people, the people who wrote that paper,
Yeah.
I said they're like Ray Gunn from the breakdancing at the
Right.
Olympics. But
Right.
here she is. She's supposed to be a fucking expert in this, a professor of breakdancing, and then just made an ass of herself and
Yes.
won't go away.
Yeah. I mean, I saw some really great Halloween costumes around her, so I kind of don't want her to go away. And I have to admit, every once in a while, I'll just go back and watch that if I need like to laugh, because it was the most absurd thing I've ever seen. And one of my best friends lives in Australia, and like, I mean, I love to be able to pick on him for that as well, because it's just absolutely absurd. There was a paper, and I believe it was I believe Peter Antevi sent it to me, as part of this. They basically interviewed women as to whether or not they would, want to get blood if they're, needed it in a trauma.
Oh yeah, he did mention that. Yeah,
I shared that with you as well, I believe. And like, I think somewhere in the high 80s, like 85 to 87% of women said, oh, absolutely. Even if there's a risk, I would want it. And then the other part of that is that, one, the risk is infinitesimally small. And second is there's a treatment for it. So, this whole idea of that is just absurd. The whole idea of, then all the hoops that people have to jump through with these, blood warmers is also garbage, because, New Orleans showed us they weren't even using whole blood. They were using component therapy, but like, it just doesn't need to be done. And if you look at, I'm a nerd. And so I look at, my degree is in toxicology and biochem. So I, was like, I'm going to look this up and see, can I figure out like how much of an effect will giving, a unit or even 2 units of blood have on your overall body temperature, even if you took that blood and delivered it right out of the fridge. And it's again, small effect, like 1 degree Fahrenheit, maybe 2.
Yeah.
It's not going to have a significant
There's
effect.
this paper from, I wrote a paper on this and I sent it to you. I don't know if you had a chance to read it or not.
I haven't read it yet, but I will. Yeah.
They always cite this paper about the need to warm the blood. And it was from 1964, I think.
Yeah.
Where they showed a 51% reduction in cardiac arrest during transfusions.
Yeah.
Which is great. But then I look at it and the patients were getting 3 to 6 liters of banked blood product. It's like, okay, well,
that's your whole blood volume. So, that makes a difference.
Yes.
The other part is no one really cares about us giving cold crystalloid necessarily. And,
True.
so how about, why all of a sudden does everyone have this, concern about giving warm fluids? I mean, if you get fluids in the emergency department, if I give you a liter of lactated ringers, right, that's at room temperature. We do it all the time. And most fluids that we give in the pre-hospital environment, same thing. Yeah,
absolutely.
Yeah. But yeah, I think we're going to talk about tactical.
We talked about that.
Yeah. And we're going to talk about tactical medicine today. So we'll probably get back to blood, I'm sure. But so that's where the TAC Medic Whiskey podcast came from. And now what I'm doing is just looking at, okay, what are some of the issues that we have, not just the pre-hospital environment, but especially in tactical medicine. I think one of the elephant in the room is, whether or not people should be armed or not. And I think, you have an opinion on that, as do I.
I do.
Yeah. What are your thoughts?
Well, I am a gun owner. I like to shoot my gun. I have never been an armed TAC medic. I've never been a sworn law enforcement officer, and I think that there is a lot of legal liability if you are not a sworn law enforcement officer and you knowingly show up to a situation that could potentially get very hostile and you're carrying a gun, whether you're part of the SWAT team or not. I just think there's a lot of liability. I also think that as the medic, so I was on the stack. I've been on the stack. The last team that I was on kind of had a similar progression through my tactical career that you did. I went through 2 different teams, and the second team I was on, I was much more integrated. On the first team, I was always on the stack. On the second team, it depended what we were doing. I mean, a lot of these Philly area row homes, they're so small, the entire team doesn't even get inside. So sometimes I was on the stack, sometimes I was in the Bearcat, sometimes I was on the last piece of hardcover. But even when I was on the stack, there were like 15 heavily armed guys in front of me, guys and girls. So if it ever came to a point where I would have to fire a bullet, that is like an apocalypse scenario.
Same. Yeah. So we utilize a very slow progression. They use a shield team, and we utilize what's called the stick. So they'll have 2 shields up front. Behind them is a light and cuff guy, and then behind them is a bunch of guys and women, men and women with rifles. And I'd be deep in the stick, and there'd be people behind me as well that allow me to know that I am well protected, and a big part of their role is protecting me, and I trust them all. I know that the team that we have, I trust them with my life, obviously.
Yes.
And I agree, I'm not going to carry a weapon, and if they got down to where I would have to utilize a weapon, that means the entire team's been wiped out, and then I'm in trouble anyways.
Yes.
Yeah. And I'm also not afraid to run. So
yeah, me neither. I think I have seen a couple TAC medics who have been like, oh yeah, I'm totally not carrying a gun, but inferring that they're secretly carrying a weapon on them in case.
Right.
I think that, I know it's a totally different scenario, but look at the Kyle Rittenhouse case.
Right.
That guy showed up to a hot event, armed, ended up shooting somebody, and you can discuss whether you think he was guilty or not, but look at what happened to him with the liability, the lawyer fees, just his life getting ruined. Everyone in the country knows him. No, for me, I'm like you. I've got enough highly trained men and women protecting me, and they want to protect me because if I go down and one of them goes down, they're fucked.
Yeah, exactly.
So if
I just 100% agree.
I just don't need a weapon.
No, same here. I mean, I go to the range. I don't own a gun. I live in Massachusetts. Don't own a gun. But I do go to the range with them, and they're teaching me how to shoot, and I enjoy doing it. I really, have a good time when I'm shooting out there with them. And they have some really good instructors, and I'm learning a lot about that. But at the same time, that's not my role there. My role is medicine, and that's what I'm going to do. So, and we practice the things that a lot of people find boring, but we do. Last week we were at the range. We did practice lift and carries. So we practice that. How are you going to carry out with 2 people, with 3 people? We practice, tourniquets. We practice, eye protection and ear protection and things of that nature that, I think that's my role, right? Is to provide that education and also to be there to provide the medicine if they need it.
I have always, you bring up the ear protection and the eye protection. I have always said, kind of jokingly, that the TAC medic is the glorified water boy for the team.
Yeah, 100%.
You have, if one of them gets shot, you have a critical role. You have a critical role in planning because the cops aren't thinking about trauma centers, what hospital has what capability.
Right.
Because our lieutenant or the guy who was in charge of our team, he world-class special operator in the military, who is now a police officer, travels the country teaching SWAT. The guy is amazing. And we would do these pre-planning, and he would be like, well, Mercy Fitz is close, so we can just take an officer there. It's like, no, they're a community hospital. And it's like, well, what's the point? The cops just don't understand the esoteric logistics of medicine that we do. So we're a really crucial part of the planning process.
Yes. Yeah. When day
to day, we're there to take care of them, to look, hey, 100%. You look like you need some water. Here's an electrolyte stick. You're the mother hen of the team. But sorry, I interrupted you.
No, that's 100% it. So I started bringing I just started this, but the last training, I was like, I really need to bring some snacks. I need to bring some liquid IV or, other electrolyte. I brought some, I brought a heater because we were at the range and they were going to be shooting. So I brought a portable heater. Like that's going to be, something I integrate in. It sounds silly, but like that's a big role, right? Is like making
Oh
sure
yeah.
everyone's feeling okay,
Mm.
making sure they're well hydrated, they're eating, they're snacking, they've got, they're comfortable.
Yeah.
We're going to talk about foot care. It's getting to be cold here in New England. So, talking about, frost nip, frostbite when we're out there. All these things are really, I think, really what, people are like, oh, what does a tactical medic do? Most of the time it's going to be those kind of things, which is making sure the team is staying healthy, that they're well protected. The likelihood that you're ever going to do anything is pretty small, for the most part, because the way we train is to make sure that our people do not get, injured or put themselves in a dangerous situation. And so most of it is going to be, like you said, the water boy, and you're just, taking care of them, getting the water, getting them hydrated, keeping them warm, ear protection, eye protection, making sure that that's all done. We, do a lot of bandaging and super gluing little, hand injuries from when we use, simunition, because, everyone's getting hit in the hand. So, those are small little things, but they're important. And, I think those are really where you play the biggest role.
For sure.
Yeah. Everyone likes to get dressed up and go out and do the cool stuff, but like most of those are over pretty quickly if it's a high risk warrant.
Oh,
Or
totally.
you're doing a lot of standing around if it's, a barricaded subject. So yeah.
Hours.
Yeah.
Hours.
Yep.
Hours.
Exactly.
That people don't realize that is a true elite SWAT team is going to slow everything down.
Mm-hmm. Yeah, that's 100% the philosophy of our team leader, which is everything gets slowed down and everything's done, conscientiously and thoughtfully. And, for that reason, it's a very safe team with a lot of really good, people on that team.
Yeah. One of the most violent, probably, I would say, of all the ops I've done, probably the most Hollywood style, with like guy with automatic rifle fire just totally going nuts. We ended up surrounding him. It was really dramatic, adrenaline pumping. We
Yeah.
ended up pinning him down and surrounding him. And we had a negotiator in the Bearcat, and our team leader, the special ops guy, said, we're slowing this down. He's either going to come out and engage us, which we will then take care of, or hopefully he's just going to get bored.
Right.
And come out.
Yeah. Which is what happens most of the time.
Hours. And that's exactly what happened.
Yeah. And I think, people also, they get hungry, they get bored. Yes. And that's how most of them end.
Yes.
Yeah.
The guy came out to try to, the guy came out. You could tell he was getting antsy. You could tell he was getting bored. Maybe the meth was starting to like level off and taper off.
Yeah. Yeah.
And he came out, beanbag round, and that was it.
That was the end of it. Yeah.
That was the end of it.
Yeah. I mean, honestly, the two most dangerous situations I've been in, one was the Red Sox World Series parade. Both Ben and I were there. And for whatever reason, they didn't want us to look too tactical. So we had our vests, which I wish we had. I wish I'd worn not my level 3A for that, because we hiked like 2 miles next to the duck boats, which was heavy. But they had us take our helmets off, and people were throwing full cans of beer onto the bus for players to drink, and like having a helmet would have been probably pretty safe. And then the other one, yeah, a good idea. And then the other one was during the George Floyd demonstrations here in the city. For whatever reason, people took to throwing water bottles at us, bottles of water, which not very dangerous. But
did you go out for the Boston Marathon bombing?
No, I was at the Red Sox game for that. Believe it or not, you
mentioned that on your podcast.
Yeah. So I was at the Red Sox game, and I was with my wife, and we got out. We went to a bar, and you're watching on TV. Oh wow, look, there's something happened. There's smoke. Maybe there was an fire in one of the restaurants. And then, we started going home, and that's when things, got crazy. But for that day. So, for those of you who don't know, on marathon day, they also have a Red Sox game at like 11 a.m. and the bars open at 7 a.m. And I get into I was there, I believe,
Sounds
at
like a good
7.
time.
Yeah, exactly. So yeah, I wasn't going to be helpful in that situation, but everything was pretty much on standby. I did have some friends in law enforcement who were at the shootout, and they said it was
Okay.
probably the scariest day of their lives.
I
But
bet.
yeah, no, that was pretty much it. Yeah,
Okay.
they mostly utilized the state police have a stop team, which is their version of SWAT,
Okay.
and they did utilize some other resources. But yeah,
Okay.
yeah.
Gotcha.
I worked in the ER the following day, and we saw some patients who were, remote to the bombing, but had like, tympanic membrane injuries or things of that nature.
Okay.
But yeah, thankfully wasn't
Gotcha.
there, and I'm kind of glad I wasn't, to be honest. Those, it's weird because all of us who are in EMS. I mean, I'm sure everyone listening to this, you want to be at the biggest and baddest events. I'm kind of glad I wasn't at that event, to be honest. I don't know.
That's understandable.
Yeah, yeah,
Yeah.
yeah, yeah,
All right. Well, back to the TEMS stuff.
yeah.
What do you
Back to the
got?
tip. So let's see. So we talked about, armed people. I think, the other piece is that it's just so vitally important to be integrated into that team. Um, I like I said, the first team that I was on, we were kind of viewed as a separate entity, and we really weren't training with them. We weren't, providing any training for them. And so when you were there, you were not really a known entity. And I think that's really critically important. I have to be able to trust my team, and they have to be able to trust me. And I feel the new team that I'm working with, that's exactly the philosophy. And I think that's critically important. I don't want to be coming up to someone for the first time and having to introduce myself, when they're lying there, and I'm going to be putting my finger in their chest or putting a tourniquet on them. And I think, having really, I think it's so vital that this gets into, it's integrated, you're integrated into that team. Which brings me to another point, which is that, really, you've done training, I've done training, there's TECC, there's all these different courses that you can take.
I wanted to bring
Right.
this up. I'm glad you're doing it.
Yeah, which is that, okay, but there's really no coordinated kind of, effort to really define, okay, what does a tactical medic do? And, not that there would be, universal protocols around this, but like best practices really should be integrated into a team, what you're carrying for equipment, what procedures, those kind of things, are certainly important. But I think the biggest piece to me is that uniformity of like, what is a tactical paramedic? What's the training going to be? And how are you integrated into a team? It is going to vary, right? By team, by, region. Some teams do use sworn law enforcement officers, others use, whatever medics are available. And other teams like the one I'm on now, like, I'm part of their team, and I'm their tactical medic, and that's my role. I think that's the best model personally. And,
Great.
having been part of all those other, things, especially the one where it's like, we're going to have you on stand. We're going to have you, you're not going to do any tactical training. We're going to have you sit in your ambulance because you happen to be on duty that day. And then when we need you, we'll call you in, right? That's probably the worst model. And then it goes, down from there. But that's what I think is that, there needs to be some uniformity and integration.
The integration's crucial because they need you. They
Yeah,
need you to be there, and they don't want just like Joe shit the medic to be showing up. I mentioned in the podcast I did that they had TAC medics who would gear up and then stay down the road in an
right.
ambulance. They never met
Yeah.
the team before. That's not TAC medics. And then
No.
on the hospital system I worked for when I was on the second team, they had, I don't know, probably shouldn't say this, but I don't work there anymore. So whatever.
Yeah.
It was pretty much who wants to be on the TEMS team. Everybody
Yeah,
raises
raise your
their
hand.
hand.
Yeah, of course. Yeah.
Everybody gets on, and the team wouldn't know who would be showing up. It could be a really good medic. It could be a shitbag. It could just be 2 EMTs showing up.
Yep.
So it got to the point where I kind of, for the time I was there, I got integrated with the team. I got to know the cops. They got to know me. They got to know who I was, my background.
Yep.
And it did happen a couple times where the team leader would call me up and he's like, hey, like, obviously this is between us. Well, I'm saying it on the podcast, but I'm not saying any names. This was years ago. He would say, we're doing this raid. This is a really bad guy. This is a shitty house.
Yep.
Can you be there? I'd be like,
Yeah, no, 100%.
Which just shows the importance of having a provider that they know and that they trust.
100%. Which also raises the selection process, right? I mean, so the SWAT medics are selected, and the team that I'm working with, they're selected. They're on probation for quite some time. They have to demonstrate their role in the team. Not everyone makes it. So why should it then be like, we'll take any paramedic, right? It should be, first of all, I agree. I listened to your podcast about, tactical EMS. It should be a paramedic. It should be a paramedic who has, those extra skill set, to provide the appropriate care. And that could be finger thoracotomy, surgical crikes, carrying blood, all of those things, right? If you're going to be doing this, you got to do it right. And so, no, I agree with you there. But
I didn't want to shit on the EMTs, but
no,
I just, I've evolved to think that if one of your buddies is going to take a round to the face, we're past the point in our ability as EMS as a whole to deliver more than BLS. BLS is great, but we can really deliver top shelf care.
Right. Yeah, exactly. And, I'm a paramedic, but also a nurse practitioner. I can practice independently, and so I'm going to bring an extra skill set there, including being able to take care of my team outside of just, tactical issues. But that aside, the selection process, I think, is important. I mean, and I like how you mentioned, people who dress up in costume, because I've seen, that before. One of the previous team that I worked on, there was a guy who, that's his whole thing. He dressed in a costume. Whether he was a good paramedic or not, I have my opinions. But and had like more stuff on his belt than Batman, and probably wasn't very, very mobile. And it's like what are you doing? And he was always the one who was saying, "Do you have your LTC? Do you have your LTC?" I didn't even know what he was talking about.
I don't know what he's talking about.
License to carry.
Oh,
so, yeah. So he's probably one of those who had a gun stuffed somewhere. But that, and I've also seen guys, and this is, I'm sure they're great paramedics, but just not in the physical shape that needs, that you need to be in to be on a team. And like it can be pretty demanding. And there are times where so I try to stay fit and, for that, for many reasons, but that's one of them.
Yeah, you got to be fit. I was just teaching a class in rural, middle of nowhere, Happy Jack, Arizona. It was a great class. It was a great group. And one of the guys in the class was telling me that he was probably going to be trying out for the TAC medic process. And he said that they had to do the exact same physical fitness test that the police officers have to do.
Sure.
And he was telling me about it. He's like, it's an 18-mile run and a hike through the mountains. And you have to do a solid minute of nonstop pull-ups in your gear. And I was like, that sounds a little nuts. Like, I wouldn't be able to
be doing that. I wouldn't be able to do that. I mean, I could drive the 18 miles, but I'm not going to be, that probably a little insane.
But you do have to have some level of physical fitness.
You have to have some level of physical fitness. Yeah. And, I think that's it. That's not a requirement of every team. But I still think that, it can be, it's important. And it shouldn't just be people dressing up in costume, like you've mentioned. It should be, highly qualified individuals with experience that are physically fit, working with that team on a regular basis, training side by side. That's what a tactical paramedic is, in my opinion.
Yeah. As far as gear, because I know people love to talk about gear. What gear would you carry?
I mean, as far as medical supplies?
And how would you carry it? So on my first team, there were 4 or 5 tactical medics, and the lead tactical medic had been in the military,
Ugh.
and therefore, no disrespect to anybody, but therefore thought, I don't know what his military experience was, but
Right.
I think he thought he was equivalent to SEAL Team 6. And
Right.
anytime somebody had a recommendation, it was, well, none of you were in the military. What do you know?
Right.
And we were carrying these massive packs.
Yeah.
I shit you not. We had bicarb, we had epi in these packs, we had blood pressure cuffs,
Right.
and we looked like turtles. And one time I slipped on the ice, and I was like a turtle.
Yeah.
Had
Yeah.
been flipped on my back.
I carry less and
there's
less.
a lot of impractical gear.
Oh, 100%. I've carried less and less now. So
Same.
I have a little pouch in the front, and that has has 2 tourniquets, and it has like a chest seal and 2 needles for decompression, and that's pretty much it, right? Because that's gonna get me out of like hot water. And then I do have a bag, and the bag basically has tourniquets. I mean, so I don't really, airway. You're not going to do any airway. I do have an eye gel in there just in case. I do. Yeah, I have an eye gel in there. But I do have some intubation equipment that I bring. But that would be, far and few between that you'd use that. But I mostly carry like chest seals, needles, a crike kit, finger thoracotomy kit, which is, very small. And I do have TXA and calcium.
Gotcha.
And that's pretty much like what I have in for the most part. So my bag is pretty small. I do have a big bag with all the toys that I could bring with me if I needed to. It could sit in the Bearcat, but I'm not bringing it with me. But it's like if I have to go into the hospital with my colleague, it's got video laryngoscopy, I've got IOs, I've got all the toys.
Gotcha.
But it's not something I carry with me. It's just that's kind of my if I had to go into the hospital with them, I'm gonna grab that and go.
The way I evolved,
toys,
Yeah.
Yeah.
The way I evolved is if I was on the stack, everything is on me that I would need.
Yeah, exactly.
Like you, very minimal. And then I did develop a bag that I would keep in the Bearcat.
Yep.
But I used to bring the whole monitor and big bag. I used to put that in the Bearcat, just thinking, okay, if I need this stuff. And then I realized you have to pre-plan an ambulance to be there. You have to pre-plan the ability to have an ambulance pull up, pick up the downed officer, and GTFO. And that was my thinking. They've got the gear. It's going to be there in less than
exactly. Yeah. So I do have that backup bag. It's really just my collection of toys for my own personal, I wanted to have a video laryngoscope, and so I have one, and it's
Which one do you have?
I have a glide scope.
Okay.
Yeah. But that's not going with me. I'm like, so what I'm going to have is just, major stuff, like stop the bleed, put a hole in the chest if I need to, kind of stuff. And so I have a small pack that it's on the front of my vest, and I have a small bag that I carry with me. And that's really it. I think I continue to take stuff out of it because it's like, well, this is not going to be helpful. This is not going to be helpful. Like, you learn more and more about, okay, well, what do I really need, to take with me? And it's pretty much not much, right? So, you're not going to do anything about gunshot wounds to the head for the most part, unless they need, surgical airway. And I have that, which is, when I say I have a kit, it's a scalpel and, and a tube. I carry just TXA and calcium. I'm not going to carry adenosine and Lido and bicarb and all this other stuff. Don't need it. So it's that's what I'm bringing in. I don't need to carry any IV fluids because
I should bring up a caveat.
Yeah.
On training days, I would bring the whole complement of ALS gear.
Yeah, sure.
I have had officers I've treated for asthma attacks during trainings, dehydration. I had one syncopize and have a tachyarrhythmia during a physical test on a hot day. So yeah,
Yes.
training days, I would bring the whole thing
Well,
because you
training
don't
days
know.
totally different. I have a whole separate bag that's like, for boo-boos, and it's got, Band-Aids, and I've got eye wash, and I've got, I bring all that stuff for the training days, because that's where you're more likely to do anything. Yeah. Give someone
Yeah,
an, yeah.
100%. And
Yeah.
you've got to be there on training days. The
Yeah.
hospital system I
100%.
used to work for, because of
Yeah.
budget cuts, no longer sends TEMS on training days. And
Yeah.
it's
No,
a
it's
big
vital.
issue for the team. The team leader was telling me it's a big issue because they,
Yeah.
as you
Yeah.
said,
Yeah.
that's when you're going to treat the patients most of the
Yep.
time.
Yeah. Yeah. Absolutely. Is you're more likely to do that kind of, stuff. Put on some, cyanoacrylate glue and a Band-Aid than you are to, manage a gunshot wound. Um,
Yeah.
for the most part. So yeah, no, I think, I do carry a whole different set of gear. I have, like I said, it's a bag that's really just for, I have ice packs, I have SAM splints, I have, all the stuff that's like, what would I take if I'm going to be doing like, standby for an event. It's a boo-boo bag. It's for, it's Band-Aids and eye wash and all that stuff. But that's not what I take with me, into um, you know, a barricade or anything of that nature. It's for training days. So that's totally different. I do also have a canine bag. I don't know if in Massachusetts, we actually have Nero's Law. Everyone has to do training on canine care. But I took the FDNY has a really good course during their MSOC course. It's 2 days with vets doing like canine care.
Okay.
And then I've done some refreshers. And so I carry a canine bag with me
Well,
as well.
the
But
company I work for
yeah,
does a
yeah,
K9. It's not hands-on, but it's
yeah,
an online distance learning
yeah,
CEU course taught by one of our guys. You're actually a great guy, Rick Miracle. He's really passionate about the topic.
yeah, yeah.
So
No, so
shameless
I have
plug.
that. I have that just in case, so I'll pull that out. We have a Marine unit, and I've gone out with those guys. So I do have a different bag for going out like with them.
What,
But
for like cutting fishing hooks out of people's
yeah,
fingers?
exactly. Yeah, yeah, exactly. Those kind of things. Yeah. But yeah, for the actual response, yeah, I mean, like I said, I've seen the costume of people who have just gear hanging all over the place, and yeah, I carry less and less now. It's really going to be like, okay, what do I need to do within the first X minutes, because then we're going to be getting that person out of there.
Yes.
So
Yes.
so I don't need to be doing 12 lead EKGs or those kind of things. Yeah, I do carry Foley catheters, but they're not. And I tease them that it's for like, I'm going to put a Foley in if you ever get injured, but it's actually for stuffing into junctional wounds. So
Oh, okay.
yeah, yeah. So yeah,
Obviously, that's in your scope as a nurse practitioner.
yes, yes, yeah, yeah,
How's that
exactly.
work?
Yeah, so if you have like a junctional injury to the neck or to the groin, you can. And I've gone from Foley catheters now to what are there. It's actually a catheter for posterior epistaxis because they're smaller. But you can put a balloon in there, inflate the balloon, and hopefully tamponade hemorrhage. Um, you know, Again, there are no randomized controlled trials looking at this, but it's something that they do in the trauma service. It's something they do in that I've done before when I was in the HEMS field. Is you've got this injury to the neck, you can put a catheter in there, inflate the balloon, and hopefully tamponade the bleeding. We actually put one in. We had a guy who walked in to our ER. He had been hit by a machete in the neck. Yeah, and we utilized it there as well. But it's a good way to tamponade hemorrhage. So I do carry now. They're just small balloons, couple of epistaxis balloons to put in there if we needed to.
Gotcha.
Yeah,
Interesting.
yeah. It's a nice. You Google it. It's a kind of I'll send you some data. It's a
Cool.
kind of cool technique to tamponade kind of junctional stuff. Because there was I have a real interest in junctional hemorrhage, and I do a lecture on it. There was a paper, I think, from like the late 1600s, early 1700s. It's a great paper. It's this narrative of this French physician who someone comes to his house and said, someone's been stabbed at the local, wine and baguette, establishment. So he goes down there, and this guy had been stabbed like around this clavicle subclavian. And he describes like taking his, neck handkerchief, I forget what they call it, bundling up into a ball, shoving it into the armpit, and then applying as much pressure as he could with the idea that he might be able to tamponade some of the underlying structures. And apparently, this guy survived. And so like, that's a really cool idea. And so I also carry, and I don't always carry it with me, it's in my bag. It's just a lacrosse ball covered with tape. And so if I had to use that, I would shove it into an armpit, or you could use it on the groin, to help tamponade things as well. So
I just had a guy come on who was in Ukraine where they don't have a lot of equipment. And he was talking about wrapping rocks in gauze and using that with a pressure bandage.
Yeah, exactly.
Kind of the same philosophy. Interesting. What else? Because people, you hear stuff about junctional hemorrhage as far as, well, they have these junctional tourniquets, but there's not much data on them. Do they work? Do they not work? Kind of the thought is junctional hemorrhages, well, they're fucked to get them to a trauma center.
Yeah, pretty much. I mean, that's it.
We can improve the care pre-hospitally, or
it's hard to say. I mean, like, I do recall we had a guy who this is back in the day when I was a helicopter paramedic, who had a bad junctional injury. I just remember having my knee in his groin all the way to the OR. So yeah, I think just knowing that there are some techniques he can do. One is compression of the aorta if you really needed to. That data comes from the obstetrical world, where they would occasionally have women hemorrhaging postpartum, and so they would basically kneel on their abdomen, and you have to apply about 150 pounds of pressure to occlude the aorta. But they would do that, for women. So yeah, I know there have been some things out there that people have talked about, the junctional tourniquets. I don't think they're really that effective. I've seen a couple of other balloon tamponade devices, but I think, just knowing like, pressure can do it. So, you might want to, you might have to put your knee into that groin and just apply as much pressure as you can and stay there until they're brought to the OR. That's a major transport problem, right? But, you might have to do that. And if you have to get into their aorta, get your knee in there and push as hard as you can, get as much weight as you can. I guess that might be where the less fit paramedics might be.
The fat guy in the costume.
That guy. Get him on there, yeah. There is a new product, and we actually they came out to one of our EMS rounds. It's called Trauma Gel. I've heard of this. Yeah, it looked pretty cool. It's basically and they make it like out of mushrooms and it's like some plant-based product, but they basically, what it does is creates a scaffolding for clotting. And so it's pretty cool. And I think that might be, something that could be of benefit downstream. It's FDA approved. They've got some good animal data. They're now trying to get, some human data.
I'm looking it up now. It says used in non-compressible junctional injuries.
Yep.
Where tourniquets cannot be applied, can be used for penetrating injuries, including gunshot wounds, stabbings, deep blacks. It's a flowable hemostatic agent.
Yeah, exactly. So it comes in a syringe. It looks like miso soup, like the color and texture of like, or like miso, white miso. They brought some videos. They showed us using in a pig model where they squirt it in, and it basically creates a scaffolding and clots. And then it's what you can wipe it away. Like once you get them to the OR, the surgeons can just, wipe it away. It's not going to dislodge the clot because of the way that it works. Like you are going to see with hemostatic gauze, right? You shove a whole bunch of hemostatic gauze in. When they go to pull that out, they're pulling away clot with it. This does not have that problem. So I think that that's something downstream that, might be of benefit too.
Interesting.
But I think you could eat it if you really needed to. It's made with like mushrooms, and so you could, if you're really hungry, you could open that up. But
gotcha.
And they have it for animals, so it's been used in the veterinary world for a while, and also in humans.
Cool.
Yeah.
Yeah, maybe that'll be in the future. You guys carrying blood?
Well, so I don't have, I'm not carrying blood, but anytime I go out, I have the phone number for Mike Volcanis, who started the whole program here in Mass.
He's still
And
alive?
he's still alive. Yeah.
Yeah,
Yeah.
they killed him.
So I have his phone number and speed dial. I have Leo Reardon, who's, one of the paramedics down there, but also the regional dispatch number, and just knowing about access to, I'm going to have quick access to it if we need it.
Gotcha.
So I'm not carrying it. I think it would be something I'd love to do downstream, but it'd be a little difficult given the way that I'm integrated into the team, because
when we were, after you and I did the initial podcast, that
yeah.
Barry, Massachusetts, the shot heard round the world, apparently.
Yes.
I did a post about Canton Fire being the first to administer pre-hospital blood, and a bunch of, I think it was UMass people, reached out and were like, they weren't the first. Our tactical team gave it first.
Yeah. I mean, whoever gave it first.
Yeah.
Congratulations.
Yeah.
But
good job.
Yeah, good. But
I think, guess they're carrying it.
I think I don't know that much about UMass and their program, to be honest. I don't know if they're carrying, I
could be wrong.
Blood. I think they were the first to give it, but I think they might have given component therapy. But then again, I'm not sure. I mean, we're going to know more about this as we start to regionalize this. So we've been tasked with trying to set up a regional system through the through the state, and so we're going to start looking at who should be carrying it, how much should they be carrying, which blood banks are they going to be affiliated with, those kind of things.
Yeah. You mentioned component therapy. That New Orleans study with the cold stored blood not being heated was component therapy.
Right. And they get component therapy. Yeah.
Even with component therapy, which whole blood is much better, but even with component therapy, the result, it was like a 34% reduction in mortality.
Right.
It was nuts.
Yeah, pretty high, which is amazing, right? I mean, this is probably the best thing to ever come along in EMS. I mean, it's out. I guess defibrillation's probably pretty high up there, but like outside of that, like when you think about things that make such a huge difference, blood is like number one. And this whole idea that it's like so difficult to give, it's just like hanging anything else. Right? Just any other fluid. Yes, people can have allergic reactions to it. Yes, there can be these, issues with compatibility, but they're pretty low, right? Those numbers, and we've talked about this data. I've sent this data to you. Those numbers are like less than 1% of those patients. And so when you think about, the reducing morbidity and mortality in these patients, right? It just seems like this should just be widespread, and I just don't understand why anyone still is against it. I just submitted an article. I think I sent it to you. You got a chance to read it, and I've sent it to some other colleagues, to a EMS quote unquote journal, and it got rejected. And one of the things that
was that the manuscript you just sent me a couple weeks ago?
Manuscript I sent you, yeah.
Okay. It got rejected.
Rejected. I'm resubmitting it, which is fine. But one of the arguments against it were their reviewer. Actually, I can just probably quote what this reviewer said. It says my message can't be displayed. But basically, he was like, this. Oh yeah, I'll read verbatim what one of the reviewers said. A whole blood program is a money loser for blood centers. Think in the hundreds of thousands of dollars lost per year for a big system. If blood centers aren't profitable, there is no blood at all. I could talk for hours on blood center difficulties in the practice of transfusion medicine. Honestly, the reason blood is slow to start in the field are complicated and involve resource allocation, which has been addressed, in my opinion, infrastructure, easy to address, donor availability, and money, and potentially a few critics. that's what the response to this was. And it's like, there's no, this is currently supported by just about every, transfusion organization, from the Red Cross to, I think there's like a national organization of blood banks. They all support this. And the idea that like we're going to waste hundreds of thousands of dollars, where is that coming from? These critics just pull this information out of their ass without any data. And the fact that they're allowed to just continually pull this data out of their ass.
It was under $10,000 for us to implement blood at my service in Pennsylvania. Right. We carry 2 units, 2 medic units. We have 2 units.
Yeah.
It was under $10,000, and we got a grant for $25,000 from a very rich family in the area. And that is our bosses say that's going to cover us for 5 years.
Oh, 100%. And so then
it's
also
not hundreds of thousands of dollars.
Not at all.
There is a hospital system in my area that is implementing pre-hospital blood, and they are saying the hospital system said it's going to cost $750,000, which seems wasteful and crazy. My boss at my full-time job said, I would love $750,000, but he said, I don't even think that I could spend that much money, getting all the toys and.
Yeah. And you don't need any of that stuff, right? I mean, that sounds absurd, but like also then, okay, let's think about the value of lives and lives saved and also ICU care, right? Which, all of these issues so you're going to say that, that the cost of implementing whole blood outweighs the cost of human lives and lives lost in extended ICU cares.
So let's look at it economically. If I have somebody gets shot, they have a blood pressure of 50 systolic, I give them blood, I resuscitate them, I get them to the hospital alive, not dead. That's a lot of ICU stuff they can bill for and make a ton of money.
Yeah, 100%.
And then they cry too much money for the blood, but then they'll have no problem forking over $70,000 for a helicopter flight to bring an ICU patient to the hospital.
Right.
Now we know, well, we're going to be able to bill them to, we'll make that money back in 2 hours.
Yeah. Oh, I mean, if we want to get started on the cost of HEMS and whether or not, moving corpses around is worthwhile, which is what happened during COVID, right? Just let's move this corpse from one hospital to another, in hopes that hospital has, some magic bullet that they can use.
Yeah.
But, that's a whole nother topic. But yeah, the whole idea is that, what we're finding is that blood given in the pre-hospital environment, these patients are arriving better, right? They're alive. Their blood pressure, their organs are better perfused. Their clotting mechanisms are not all out of whack. And so they're having decreased morbidity, not only decreased mortality, but decreased morbidity and shorter ICU stays. And that is a huge investment, right? So we're making a huge downstream difference, in my opinion, by integrating that. And so, all these people, these critics who, for whatever reason, never have to present any of the data for their wildly inaccurate statements is ridiculous. And, it just needs to stop. And thankfully, there are people out there like Peter and Tevi who are just able to wave that flag and say, no, here's our data. This saves lives. And we don't need an RCT.
I also think you hit the nail on the head using health equity as a way to get the blood implemented. Cause that's totally thinking out of the box.
Oh, 100%. Yeah.
I mean, you're bringing blood to the point of injury, and it's to, let's be honest, who gets penetrating trauma in our society in the urban areas? Some of the socioeconomically disadvantaged, they're often minority ethnic groups.
Yep.
And we are delivering life-saving, cutting-edge care right to them in their communities, which to me, I'm not a Harvard bioethicist like you, but that sounds like the epitome of health equity.
Oh, 100%.
Social justice in healthcare.
100%. And this whole idea, and unfortunately, one of the big critics here, or two of the big critics, they're both EMS fellows, for whatever that means. I know some good programs that have EMS fellows, and I know some really bad EMS fellow programs, but like, they're both EMS quote unquote fellows who have, allegedly done some sort of fellowship in EMS. And they're like, well, the hospitals here are so close that you don't need, to bring blood to them. But that tells me that they've never really done real EMS, because
Correct.
you cannot just take someone and magically, who's been shot. They're not going to just magically appear in the ER within 10 minutes, right? There are logistics beyond logistics for getting even the simplest, of those patients oftentimes to the hospital.
Well, the Duchenne study, I think it was the Duchenne study, showed that penetrating hemorrhagic shock patients that got pre-hospital blood got blood 18 minutes quicker,
right,
than had they presented to the trauma bay.
Right. Yeah, exactly. So even those getting to the trauma bay, right, there's going to be a delay in getting blood to those patients. And so, I don't care where they, I guess if it's across the street from the hospital, we could probably get you there pretty quick. But, especially in a shooting, right, there might be a safety issue that, scene has to be cleared. So now that patient's been bleeding for a while, or just the logistics of getting them wrapped up into the truck, moving, down to the, into the ambulance, getting them those are minutes that we're losing. And if we aren't giving them the blood, then they're going to have worse outcomes. And, it's so that whole argument, and New Orleans demonstrated this as well, right? That it doesn't matter about proximity. It's all about getting the blood in early and getting it there faster. You're not going to be able to get it any faster than in the pre-hospital environment.
Yeah.
Yeah. And the other piece of the whole, thing about blood is that the biggest waste of blood is not in these trauma patients. It's the day-to-day, people getting blood transfusions because their hemoglobin's 8 and they're feeling tired. These like come from a nursing home, 88-year-old coming from a nursing home with, iron deficiency anemia, who's coming in just to get transfused 2 units of pack cells. First of all, those pack cells do practically nothing, but it's like that's where the wastes are. So if we want to look at waste, and I know emergency medicine doesn't like to look at itself, they're much happier bashing EMS with most of the time. But like, look inside. You waste more blood in the emergency department, and honestly, we waste a lot of it in the ICU. We waste a lot of it on the floors doing these unnecessary transfusions. And so, like, we want to look at waste. Let's look at that. But no one wants to look inside. No one wants to.
You hit the nail on the head about that. I was looking up because, oh man, you're right. Emergency medicine does not like to look at themselves. No. I was trying to prove naively, because I knew there wasn't going to be any data on it, but all this stuff about paramedics sucking at intubation, which some do.
Yeah.
But I was like, I bet you that if you honestly compared ER physician rates to our rates, they would be similar. And I went and looked, and you can find a ton of data on paramedic first pass success rate. You can find jack shit about ER physician first pass success rate.
Yep. You and I think alike, because I've done the same fruitless investigation to try to look at, whether or not, what the first pass success rates are, especially when you think about interns, residents, right? That's a huge area. But like, intubation's not a regular, it's not happening every day in the emergency department. And so their exposure to intubation probably is equal to that of, of a good paramedic system. I'm guaranteed the rates are about the same, right? Except they probably have a few more tools, and so that might be beneficial. But there's nothing out there. They don't want to look inside, and that's the Wizard of Oz behind the curtain stuff that no one wants us to look at. And similarly, I love my anesthesiology colleagues, and if I do have something really fucked up, I'm going to call them to do like, a bronch or something of that nature. They're great for that, but like, they're not typically involved in emergency intubations either, right? So when we think about, that vomiting patient, blood in the airway, all that stuff, right? Everyone's going to have difficulty doing that. And so, you think about, I think that it comes down to, the biggest issue is exposure to that procedure. we've already screwed that up by putting too many paramedics out there. No one's going back to the OR to do training. No one's doing, practicing it. So it's really a system-wide problem, in my opinion, that, I don't see a great fix to it, except that, if you're going to write an article and say that our paramedics can't intubate, okay, well then how often are you bringing them to the OR? And how often are you doing mannequin training? And what tools have you provided them with? If you're going to, go out and say that, your paramedics can't intubate, I don't think taking that skill away is the right thing. I think improving the education around it is the best thing to do, but no one's willing to do that. So,
yeah. Well, we've covered a lot. Is there anything, talk for an hour? Is there anything else you want to bring up?
I don't think so. I think, I'm just looking forward to having a nice, peaceful and relaxing Thanksgiving. And I'm big into, I love turkey, and I use the Martha Stewart recipe. It's an all-day.
I just watched the Netflix documentary on Martha Stewart.
I'm going to be watching that soon. Yeah, it looks like it's pretty good.
She was quite the smoke show.
Yeah, she was. That is true. That is true. And is Snoop Dogg in that, by the way? Because
I think towards the end.
Yeah. If you've ever watched that show where she does a cooking show with Snoop Dogg, that is off the rails. But from an EMS perspective, I think in tactical EMS, we've covered a lot of topics. I think just to kind of shore it all up, bring it all back together, is if you're going to be working in the tactical environment, you want to have the right gear, protective gear. That's critically important. You want to train with that team regularly and be integrated in that team and carry the right gear. I think those are important. In teams that don't do that, it's probably not safe. You're probably not working in a safe environment. Would you agree?
100%. Well, excellent. Everybody, check out Steve's new podcast, the TAC Medic Whiskey Podcast. It's on Podbean, right?
Podbean, and I think it's Apple Podcasts. You can find it there as well.
Oh, cool. Excellent.
Yeah.
All right. Well, let me stop recording and then I'll